We will call to order the regular meeting of the Board of Trustees, and I will turn it over to Christy for the presentation of the budget.
Okay, so the first thing we always do every year when we do the tax budget is compare our rates to other facilities in the state of Iowa. So I apologize, I pulled the wrong ones into the PowerPoint, so I pulled up Jeff's pulling up the actual ones here. So based on the rate that we've currently had for the calendar year 2022, we were at $1.13 roughly per $1,000 of valuation, so that compares us. We're pretty low in the state of Iowa, as we had been
15th lowest, right?
15th the lowest. Yep. How do you?
I'll switch.
Okay. So, and then if we go to the actual tax asking, we are ninth in the state for the lowest amount of tax collected to support the hospital. So we get $1,062,650, and of that, $1,048,487 comes from actual property taxes. The difference is that how they tax utilities in your county, so that's the difference. It's taxed a little different rate there. So we are ninth. So we are still very low in the fiscal year 2020. I'm going to go back to the PowerPoint. So, and these are just slides taken again to reiterate that, as Jeremy Behrens had pointed out when he did our audit presentation, again showing us as our rates is how we have maintained our rates pretty consistent. And we are lower than most at the average hospitals in the state of Iowa. So it just reiterates more of a visual format what our property tax rates are doing.
What's the highest, Christine?
It's the highest.
Yeah.
I got it up here.
It's all right.
$3 and some cents is the highest for.
So double what we are. Yeah.
And Broadlawns in Des Moines gets quite a bit of property taxes levy too. So $3.66, which is Davis County. There's really nobody close that's, as a rate, Red Oak is the closest hospital with one of the higher rates. All that depends a lot on your property tax valuation, so that if you have a high rate, it doesn't necessarily mean you're going to get high property taxes. It is dependent on the valuations in your county. So again, just to reiterate, as Jeremy had pointed out when he went through our audit report, how we set our rate based on our asking, so what our dollar amount is versus just setting our rate and staying with the rate, and just as valuations go up, then our collections would go up. So this is just a summary.
Very responsible.
Yeah. It's good for our taxpayers. So the tax valuation for this current fiscal year ending in June 30th of 2022 was $938,867,000. For the 2022-23 budget year, it was $960,855, which is a $21 million, almost a $22 million increase in taxable valuations. So that allows us to get the same tax asking of the $1,062,650. We can take our rate from the current rate of $1.31 down to $1 and roughly 11 cents. So we're reducing it about 2.5%, 2.5 cents. And this is what we published in the paper. This is just a copy of the public hearing that goes in the paper that shows what our tax budget is, which we operate internally on an operating budget, which we bring to the board in May or June. And this just gives you a little bit more background. It's a little easier to see where the tax rates come from. Our general tax levy is 27 cents, which can be used for like maintenance of the facility. Most of our property tax comes from for Social Security taxes. That's one of the areas that we can levy for, and that's 0.72 cents. And then we levy for ambulance services. What we support the ambulance commission to provide ambulance services in the county of $112,000, and that's 11.6 cents per thousand. So it just kind of gives it a little bit of breakdown. Any questions on the property tax rate and the budget for next fiscal year?
Nope.
Okay, I would request a motion to approve the proposed budget at the tax rate of 1.10594 per thousand of taxable valuation, generating $1,062,650 from property taxes and utility excise tax.
I would make that motion for the approval of that tax request.
I'll second it.
All in favor say aye.
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 Motion has been approved. Okay, and next on the agenda is departmental educational revenue cycle, and that's Jamie Hossel.
Good morning, everyone. I'm going to talk to you today about the No Surprise Act. So effective January 1st this year, the No Surprise Act went into effect for out-of-network payers that patients may have, and the good faith estimates for uninsured patients. The first part of the No Surprise Act is the balance billing, which is your out-of-network insurance. When patients would see a doctor or a provider, they may, you have your co-payment, your deductibles, but if you have an insurance that is out-of-network with that provider that doesn't have a contract with that insurance, a lot of times these patients were paying the bill in full. I'm a little nervous, so excuse me. So that was called balance billing, when the provider would balance the whole bill to the patient. So the Surprise Act is to help protect the patients. And, most of our patients don't really understand their benefits with their insurance companies. Especially if you're traveling, you may have to go to the emergency room and you may see a provider that is out of network. So here on the second page is just kind of a snapshot. If you're going to the emergency care, you would go to your closest hospital, and your total bill could be completely out of network. Or you go to a hospital and they're in network with your insurance, but some of those physicians could be out of network. Your radiologist, your assistant surgeon, anesthesia, pathologist, especially if you would go to the city like Omaha. Sometimes those physicians are not always in network, and you pay more out of pocket for those services. All right, so we have to provide a notice to our patients, and it's posted on our website, on the myrtuemedical.org website. We have to get a consent from the patient for the non-emergent, for the out-of-network services. And we've implemented several different workflows. Currently, the University of Iowa supports our EPIC system, and they've created some workflows in that EPIC system. And we are currently doing additional network flows for scheduling and registration as well. So the patient is protected from balance billing for like your emergency services. Oh my gosh, my thumb's not working today. So basically, if the patient comes into your emergency room, the patient cannot be balanced for the emergency services, so we cannot balance bill those patients. So they are protected in this No Surprise Act. So if a patient would come into our hospital here at Myrtue for surgery, and they would have an insurance company that we don't have a contract with, which is out of network, or emergency room services, these patients can't be balance billed, and we may not ask the patient to give up the protection not to be balance billed. And sometimes we have patients that come in, they have a surgery, they may have a biopsy. Well, that biopsy is sent to a reference lab in Omaha. Sometimes those services could be billed from that reference lab, which could be out of network for that patient too. But the patient's never required to give up their protection for balance billing. Okay. So the health plan covers emergency services without an authorization. We have to cover the emergency services by the out-of-network providers. And based on what the patient may owe the provider or facility on what it would be, an in-network provider, and show that amount in the patient's EOB. And then count any amount the patient paid for emergency services or out-of-network services towards their deductible or out-of-pocket limit. The second part to the No Surprise Act is the good faith estimate, which is for your uninsured patients or self-paid patients. And when those patients schedule an appointment with our hospital, we have to provide that patient with a good faith estimate. So we have to estimate what their services are going to be. If it's like a radiology exam, that's pretty straightforward. We can pretty figure that out. But if they're seeing a specialist, it's hard to determine what those services are going to be, so we do our best to determine what services. Sometimes there may be procedures that are done that we cannot predict, but we have to be within $400 of that estimate. Even if the patient would be like an inpatient here in the hospital, we have to provide a good faith estimate. And if services change, we have to do another estimate to indicate the patient, especially if they would have a procedure during that inpatient stay. We have to go through, do the estimate, and give it to the patient. And here's just kind of a snapshot of what the estimate would look like for an office visit. And we have to include your uninsured discount or charity care discount too on the estimate. And like I said before, we are doing some new workflows and scheduling. We're testing that out this week. They will be asking more questions to the patient, such as, do you have insurance? Yes or no? And what that will do in the system, it'll create that scheduled appointment to drop into a work queue for our patient financial advocate to do the good faith estimate. And then if they're out of network, we have to have them, we give them the option of sliding off on that out of network, so we can't balance bill them. So that's pretty much about the No Surprise Act.
How do you pick the provider that they're going with then, like that you're going to compare it to? Because you've got Medicare and Medicaid.
We don't have to do that for Medicare and Medicaid. It's basically your commercial insurance for the balance
bill. Like
bill.
a Blue Cross Blue Shield then, that you're basing it off of?
Policy.
A group, just a general group?
No, the system, Epic is aware of which policies you have, and then we have a service that it goes out and it pulls your benefits in based on your insurance plan.
Gotcha.
And
But
then
even though it's not in
it-
your network, you would know what, say, this
Right.
Yes.
system would pay if you were in network.
Yeah.
Okay,
We
gotcha.
could pull it through the real-time.
I was understanding
eligibility.
that you were going off some other general plan.
No, we pull their benefits in.
Okay.
We've got the real-time eligibility built in with the Epic system, so.
And how it basically begins the estimate process is it looks at our historical. So if you're going to come in and get a knee, it looks at all of our knees that are out there that we've done here, and then kind of averages that cost. And then it takes that and goes out and looks at your insurance company, your policy, and says, this is what you have left on your deductible, this is your normal copay, and this is what you would be responsible for.
Interesting.
Yeah. So
It's nice
it's,
this system will do a lot of that.
it,
I was gonna say, another reason to celebrate Epic and.
Yes,
the service
definitely.
that's within
I
it.
couldn't imagine having to do that if you didn't have something like that to work.
Right.
it would make it very difficult to know every patient's benefits.
Gotcha.
But with Epic, they have really great workflows in the system. So it starts with scheduling, goes to registration, it all flows through the system, so great things. So, all right, thank you, everyone.
Thank
Thank
you,
you.
Jamie. Okay, I'll need approval for the minutes of the January 25th, 2022.
So moved.
Second,
It has been moved and seconded. All in favor say aye.
aye.
Opposed, the same. Okay, we'll have the medical staff meeting summary. Karen?
Yeah. Dr. Martin's been off, so he taxed me with this one today. So medical staff met on February 8th. Of course, always started off with our favorite topic of COVID. Basically, on this one, we were talking about our inpatients, so our patients who are in the hospital. The CDC did lower the isolation time frame for these patients from 20 days down to 10 days. Different levels of patients, et cetera, but basically all of our patients, or I'd say 99% of our patients who are admitted with COVID are on oxygen. That puts them in the highest or the most critical level. So most of them were at the 20-day isolation time frame, and CDC brought that down to 10 days. So very nice for our patients. They could get out of isolation. Basically, that meant that then they can have visitors earlier. So while we were talking about that, we did also talk about our visitor policy. And we actually did change our visitor policy, allowing 2 visitors for COVID patients from day 1. So basically, those visitors have to be educated, they have to wear all their masks, PPE, et cetera, but we're allowing them to come in earlier. So very nice for our patients to be able to have their family members come in and meet with them at an earlier time frame. So discuss that with medical staff. Glycemia policy, so we do have a policy for our diabetic patients who are in cardiac rehab. And when they come in, we do blood sugars, both pre and post exercise for their first 6 sessions, just to make sure they're doing okay with their diabetes while going through all this exercise. So went over that with the medical staff, went over the parameters. Basically, it's a kind of a standing order that if their blood sugar gets too low, et cetera, that they can have some leeway as to what to do with those diabetic patients in cardiac rehab. So medical staff reviewed that and approved that policy. Kim Burchett, Rural Health Clinic Manager, joined us for the meeting and went over a few things. One of them was the Health Track Pharmacy. This is a outside a pharmacy where we can do a viral swab. So basically it's a one swab, nose or throat, depending on what the patient's needing. And it goes out to an external lab and turns around, and they can do a lot of different viruses on one panel. Not something we can do here with our equipment. Kim was basically talking with medical staff, letting them know that we have this. It is, again, a 24-hour turnaround. So if it's something that we want to know quickly, if you have strep throat or if you have COVID or those types of things, we want to know that pretty quick, so we do that in-house on a one swab, one test type of thing. But if they want to do a whole panel and find out some other weird different viruses out there, they can send this out to that lab. So she went over that with the medical staff. Kim discussed with the medical staff the possibility of purchasing a retinal camera. So for our ACO, we need to do, or they recommend us doing like a dilated eye exam for our patients. And this retinal camera would basically be a pre-screening, very good for like our diabetic patients, again, if they're not seeing their eye doctor very often, that we can also, do an eye exam while they're in the doctor's office. So talked about ordering that. It would have to be reviewed by an optometrist, but if everything goes okay, then, again, it's a pre-screening. If they fail the screening, then they would have to go see their eye doctor, but it's a good way of getting that eye exam done in the clinic. Kim talked with the medical staff about our immunization numbers for the previous calendar year from all of our clinics. We are doing the drive-up COVID testing. Primarily the drive-up is for our telehealth patients or people who are maybe traveling, not necessarily needing to see the doctor per se unless they've done a telehealth visit. So I've been doing the drive-up testing. Kind of varies. Usually our Mondays and Fridays are a little heavier, in the middle of the week not so much. So just talking about the medical staff, letting them know we were still doing that. I went over the Red Cross blood supply. I think we talked about this at our last meeting, but they are at critical low levels at this time. Basically, they're having less volunteers coming in due to COVID and winter weather, as well as having their own workers being sick and not coming out. So basically their levels are at a critical low. So we discussed that with medical staff, and they're definitely evaluating patients one-on-one basis before giving blood if they don't need to, kind of being a little more conservative with their blood administration. The University of Iowa, our cardiologists who are coming out to our facility have been ordering a lot more IV Lasix drips. So we did share with the medical staff the University of Nebraska's Lasix drips protocols. So just went over that with them. Carrie Sonderman from Diagnostic Imaging joined our group and discussed the new guidelines for age requirements for low-dose lung cancer screenings. And then also for those low-dose lung cancer screenings, we have follow-up exams, so both short-term as well as annual exams. So rather than having to send a message to the medical staff, would you like to order this annual exam, etc., we kind of talked about a process where Diagnostic Imaging will order those, the medical staff have to prove it, but then it's already on the calendar. We can let the patients know your next exam will be in 6 months or 12 months, that type of thing. So trying to streamline that process, and they still have to approve it and be okay with it, but then they don't have to be the ones actually doing it. The Diagnostic Imaging staff can do it for them. And last, Christy Mattis joined the group to talk about our new tele-intensivist program. So this has been very exciting for us to have, especially with our sicker COVID patients. So these tele-intensivists are oftentimes like a pulmonologist or an expert in those, especially the respiratory, et cetera, issues with our COVID patients. So through telemedicine, we can have these consults with these specialists right in the patient's room. So basically, there's two different things you can do. You can do a kind of an emergent, where we call the physician and say, I got this person, they're really sick, kind of want a second opinion or want to know what you're saying, type of thing. And they'll come in within a couple hours usually and look at the patient. They can get into Epic and look at all their labs, x-rays, etc., and kind of help the practitioner manage that patient, especially as our patients who maybe are going downhill kind of quickly and we want to transfer, but we haven't been able to get a transfer very quickly lately. So this gives them another set of eyes looking at that patient, stabilizing that patient before we have to transfer them. The other option is a consult. So again, a pulmonary consult. We have Dr. Mukherjee who comes out, a great pulmonologist, but he's not here every day. So this gives us the opportunity of any time, any day to have the pulmonologist actually view these patients and give their expert opinions on them. And that has to be done within 24 hours. So just talking with the medical staff about the whole process, if it's an emergent consult, the tele-intensivist wants to talk specifically with that doctor right away, so the doctor needs to be available for them. The consults can be, again, they can be within 24 hours, so a lot of times they'll just put a note in Epic letting our doctors know, what they think, what their opinion is, etc. So nurses have been given education on how to run the equipment. The intensivists have been great to work with, very easy to work with. So we've had quite a few consults since we started, and it's really going very well. So very happy to have that service for our patients. Any questions on any of that?
Good reports. And I'm interested in the whole retinal pre-scanned?
It'll be interesting to see. I don't know a whole lot, like I said, she was just bringing it up with medical staff to see if that's something they'd be interested in, and then we'll have more.
And you said just for diabetic patients, or would this be?
No, it could be for any patients, but especially our diabetic patients where, they can have, things can be happening with their eyes that maybe they don't even notice.
Sure.
So it's a good pre-screen for them, especially if they're not seeing consistently their optometrist.
Thank you, Karen.
Thanks, Karen. Okay, Tammy Harlan is going to give us the auxiliary annual report.
Okay. So our annual meeting was held April 2nd, a little bit later than usual, due to COVID stuff. Our total membership was 225. This year the auxiliary made, instead of doing our traditional Valentine's tea, we packaged up cookies and took them to each individual department, and that was very well received. Our team consisted of Deb McCarthy, Patty Miller, and Judy Storm, along with Wave of Bells and Bonnie Fiscus. The spring fling that we usually do was canceled due to COVID. We've also decided to kind of discontinue that fundraiser altogether. It was just a lot of work and not much return for the effort, so we're doing our linen sale instead, so that's kind of took the place of the spring fling. The pop tour was canceled this year due to COVID. Our Look Good, Feel Better program is available for wigs, wraps, and shampooing for our patients, and we have volunteers from Secret Serenity Salon for this program. Jan Gieser chairs the Spring Bed Visitation Committee, and these volunteers stop by and visit with skilled care patients. These services resumed in April. They were excited to get back doing that. The information desk volunteers are still not back due to COVID. We continue to provide coloring books and crayons for the pediatric patients, and we also provide stuffed animals with the MMC logo to the surgery department. We also continue doing crocheted stocking caps and Afghans for the newborns. Let's see, we gave out our 5 $800 scholarships, as well as the Donna Faye High Grade $800 scholarship. Bonnie Fiscus and her team organized that project, and that money is funded by our Bakeless Bake Sale. The bazaar was held on September 9th at Vets Auditorium. Our theme was city shopping in a small town, and it was co-chaired by Shannon Barley and Susan Hogsett, and we made $7,300 from that fundraiser. The linen sale that I talked about from the Geneva Sheet Company, we raised $1,450, and that was held October 11th. We're having a hard time finding one manager for the gift shop, so we kind of split up the roles to different women this last year. Deb Duran took over purchasing. Ruth Ann Grimsley took on the financial, Bonnie Fiscus and Patty Miller display the purchases, and Susan Hogsett schedules the volunteers to work in the gift shop. We also bought a computer system for the gift shop, so everything is barcoded now. It's a much more efficient way of doing things in there. So the gift shop now takes credit cards, and it's open Monday through Thursday, 10 a.m. to 1 p.m. This was last year. Fridays, 10 a.m. to 1 p.m. We've now extended those hours to 4. The gift shop open house was held. The holiday open house was November 11th and 12th, and I don't have that number exactly of how much we brought in on that. And our Tree of Lights fundraiser, as always, was very successful. The dues are $10 a year or $100 for lifetime membership. I also have from the hospital auxiliary, our net income last year was $8,987.22. Is that right? Am I reading this right?
That sounds like a
I'm
good
good
year.
with these numbers, so. Yeah, so thank you.
What department wouldn't be happy to get cookies brought to?
It was great. It was.
Yeah, that was, it was fun.
That was a good alternative for lots of reasons.
How is the membership going?
We had, our total membership was 225.
And does it compare higher or lower from your?
It's decreasing. Yeah. We've also voted to decrease the number of board members because we're having a hard time replacing people as well, so. Yeah, we're struggling, but we're.
Thanks for
we're
everything
still-
you do for our hospital, you guys do a lot. We really appreciate that.
Much appreciated. Thanks for the report today, too.
Okay, quality improvement report, Laura Friend.
Okay, I am just going to take a few minutes and talk about Compass, which is our healthcare quality improvement contractor. In September of 2020, CMS announced that the IHC, Iowa Healthcare Collaborative, would be one of 9 contractors. So we are actually in our second of 4-year terms. Compass encompasses 5 states. They actually just recently added Alabama. But under that umbrella is 275 critical access hospitals, 8,000 clinicians, and 24 communities. The Iowa Healthcare Collaborative, the aim is at advancing hospital quality and preventing and patient safety. So that's really the goal of IHC. And if you can see down on that last bullet point that they've really prevented almost 37,000 errors with a huge cost savings. Now, the hospital, there's multiple different work areas. We at Myrtue have identified 2 as our priority areas. One being behavioral health, and that we're looking at patients who are screened for clinical depression. If that's a positive screening, that a follow-up plan is being completed. Last year, our results, we had an 18% improvement from the prior year, and we're going to continue with that goal in 2022. Care transitions and readmission reduction. Now this is really kind of looking at annual well visits for Medicare patients, and there's some brochures on the table that our health coaches are giving out to patients. In 2021, we saw a 26% increase in that, and we're continuing with that same goal too. That's really a focus on preventative health. It's a preventative plan that health coaches are meeting with the patients first, and it's collaborative between health coaches and the providers. So they meet with the health coaches first. I spent some time talking to them yesterday, and some of their successes were finding a breast cancer, finding a lung cancer from a low-dose CT scan, and then bone disease through DEXA scan. So those are all some of their recent successes. Those are our 2 priority areas, but there's 39 total measures that are either reported via the portal or through claims data. So it's really collaborative from multiple areas in the hospital, OB, med-surg, infection prevention, pharmacy, and it's really everybody working together to report and meet those 39 measures. The last is just a quote from the president of the Iowa Healthcare Collaborative stating, "We believe our work is deeply rooted in the innovation and evidence-based practices and should be broadly applied as healthcare in America faces perhaps the most profound challenges." So any questions on that? I do have a few department QI reports too. Drew Becker from maintenance, he reviewed the annual inspections reports, and this is throughout the hospital and all the satellite clinics, and reviewed the annual requirements for that. Medical records monitored documentation for compliance. Surgery completed a focus study on maintaining appropriate temperature in the OR, and that went really well. And they also look at making sure all patients meet the surgical screening criteria. Infection prevention, of course, has been very busy with COVID and all of the requirements, and doing a good job of keeping up with all of that. Steve Finn from Rehab Services, he monitors the completion of fall screenings. So So when patients come in, that they're screened for their fall risk and injury, and that they've signed the plan of care there. Dave Bauman from Senior Life Solutions reported on documentation and referrals to Senior Life Solutions, which was really good. And Nicole Olinger in outpatient specialty clinics evaluated hand hygiene, and then assuring that patients are getting their after visit summary. So when you come in and you leave your appointment, that any instructions that you have are included on that, as well as your vital signs from that appointment. And sometimes you don't always hear that the best at the appointment time, so they're receiving that information. And that's all I have.
Thank you, Laura, and congratulations.
Thank you.
Look forward to working with you.
Thank you.
Okay, next on the agenda is approval of the Personnel Committee report. I guess Rick is not available. How about
I'll
you?
do it, yep. So we met this morning at 7. We had 1 initial appointment, 4 reappointments, 1 expansion of privileges, 3 voluntary withdrawals. I'll make a motion to approve.
I'll second the approval.
Thank you. All in favor, say aye.
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 Thank you. I guess next on the agenda is the CEO report.
Okay, so as you know, we are the recipient of $1 million USDA grant to renovate and expand the emergency room department. So I wanted to give you a little bit of an update on where we're at with that. We are looking at architects. We're interviewing architects. I think we've got 5 different architects that I think we've done 3, and we have a couple more that we will look at for that project, and want to decide in the next month so that we can take that to the next board meeting to get approval to hire the architect for this project. We're also looking at possibly using a construction manager for this project. So we will, at that March board meeting, if we decide to go that direction, we would ask for approval to contract with construction manager as well. So if we can get started, say April 1, we would expect to be able to go out for bid October, November timeframe, and then begin the project in the spring of 2023. The project has to be complete within 3 years, so January of 2025 is when the project would need to be complete. Some more information about the grant itself. The purpose is related to COVID-19 testing and vaccines, but it's also related to rural healthcare services in general. So the ER itself fit very well into this project, and as you know, that's been part of our master facility planning. The ER has been a big part of that. So that was it made sense to go that direction with this grant. The application did require a high-level architectural drawing with an estimated cost, and that estimated cost was $3.8 million. But as we're meeting with these various architects, they're all telling us the same thing, that it's extremely difficult to estimate what anything's going to cost next year, and we've kind of seen that with some of our last few projects. Obviously, we've been way off in estimating. The architects have been way off in estimating the gift shop and cafeteria, the cut project. So it's still very difficult to estimate what these projects are going to cost, but I'm assuming that $3.8 million had some fairly considerable contingencies included, but some of the things that we would like to accomplish with that project is more exam rooms is an important part of it. We want to include a behavioral health room, which has really become more necessary over the last several years. The nurses station, we want it to be more centralized with better line of sight to all the exam rooms. Admissions, we'd really like it to be adjacent to the nurses station and not separated the way it is now. And we also would like to have a lot better confidentiality at reception, at the admission desk. And then improved ventilation system is the other area that we would like to see improvement on. So I think that's my update related to the USDA grant, the emergency room project. Any questions on that?
Is it a cost share one, like you have to spend $3 million?
Yeah, we'll have to spend, I mean, so we estimated 3.8 million, we'll have to spend 2.8 before they kick in, and then we'll have to spend that full 3.8 in order to get the full $1 million grant.
Which probably won't be a problem.
I think so.
I would imagine that. That would be a nice upgrade for the facility.
I did just want to give you an update. So with Dr. David Vendorf leaving, we have contracted with a search firm, Jackson Physician Search Group. We did have a call last week. Jill and I had a call last week with them. They'll probably be doing a site visit here in the next couple weeks. And then that will be marketed here probably starting this week. That will be out there for physicians, general surgeons to be able to see that this opportunity is out there. So I'll keep you posted on where we go with that and let you know what the progress is on that search. I did want to announce that we were named a top 100 critical access hospital again this year. So that's top 100 out of 1,300 critical access hospitals, and it's the Chartis group that does that award now. So that's the last 10 of the last 11 years we've received that award 10 times, and there's only 7 hospitals in the nation that can say that have actually received that award at least 10 times. The one year that we didn't get it was last year, and you know, they score every hospital in the United States. So every critical access hospital gets a score, and then they rate you. They give you a percentile. So our percentile this year was the 95th percentile, meaning we scored better than 95% of those 1,300 critical access hospitals. So we did see the last year's percentile was 91st percentile, which just barely fell out. You had to be at the 92nd percentile to 92nd or 93rd percentile to get into the top 100. So even though we didn't make it last year, we were like just very close. And really, I think the thing that took us under was our financials weren't quite as strong as they always have been, and you know, a lot of that had to do with COVID. So I just wanted to make you aware of that. They do use they use publicly available data. We don't submit anything for this award, and all the 1,300 critical access hospitals are scored. There's 36 indicators revolving around market share. They look at quality, outcomes, patient perspectives, cost, charge, and overall finances. So, you know, just want to thank all of our staff. I mean, even though it's been kind of a tough couple of years, our staff have really responded well and have been resilient and really have done a great job. And just want to thank all of our staff for their work.
That's wonderful.
That's quite an accomplishment.
Okay.
Everybody.
Then we are still, I think I mentioned to you that we're working on a rheumatologist. We've had a couple visits set up and they had to be canceled. But there's a rheumatologist out of Omaha that we're hoping to get out here, do outreach a couple times a month. So that will, I think did we get that scheduled yet? Okay,
March.
so. But that's one of those specialties that we haven't had for several years, and it's definitely one of those specialists that we need out here. So we got the neurologist, which was another one that we had not had for several years, and really neurology and rheumatology were two of the top specialties that we were really looking for. So hopefully I'll have some good news on that here next month. And just, Jeff, do you want to say anything about the central utility plant project?
The project is moving forward feverishly. Since the last meeting we had, some of the things that were accomplished is we got all the condensers hooked up, they're powered, they're plumbed. However, we did find one valve that is malfunctioning that has to be replaced. The estimated turn-up on those is in about 2 weeks. So that'll be a nice accomplishment to get all of the cooling on the new system. So they continue to work outside. Next week we'll see people here framing up the retaining wall and start hopefully later the dirt work to backfill all of that. We still have the propane tank to put the foundation on that, and so that should be done in the next couple of weeks also. So outside is getting close to complete. We continue because of the temperatures, continue the work inside. All of the condensers, the pumps for all of the cooling system are all in place. We have the pad poured for all of the heat pumps or boilers that are going to go in. Next week we should see somebody that will be in to cut an opening on the south side so that we can move all that equipment in. They have to bring in some specialized equipment to lift it. It's about 2,000 pounds each, and I think there's 5 that are going to be placed in there. So they continue to do the power, the plumbing, everything there. We also, in the next month, should start to see one of the boilers, existing boilers, be dismantled and removed out of the central utility plant. We'll also start to see this week, maybe today, some work that is going on the interior hallways. We have to do some plumbing there to get from the old boiler room, which is behind maintenance, to the new one. So some of that plumbing is going to start. We also have new humidifiers and heat pumps, air conditioning units that'll go into the surgical area. So those will start being framed, and we'll mount all of that hardware in the next couple weeks. So a lot of work's been accomplished, a lot still continues, so they are moving forward.
Fairly good schedule, on schedule yet, or?
It's still, yeah, end of August is still the targeted time. They are still saying that it'll be prior to that, but supply chain on this one valve, we hope it'll be here this week yet. It's a simple replacement, but acquiring that is the challenge. So they still tout that they are on track for a June timeframe completion, so which is really nice. Let's see.
It's good to hear that, because when you drive by, you just get a bit cold.
Yeah.
Nothing's happening. And,
yep.
I think that's what people perceive, that there's nothing happening.
Yeah,
so it's good to hear that.
Yeah, you don't see it because a lot of the work is inside of the boiler plant. And then also, if they are working out in the condenser farm, they're down below grade and you just can't see them.
Yeah, because that's a big hole.
Yeah. Yep.
Thank you, Jeff, for
You
the
bet.
update.
Thanks.
Before I finish my report, this is Ann Buman's last board meeting, and Ann's worked for us for 35 plus years, and I know since I've been the CEO, she's worked in quality and risk management and worked with medical staff on bylaws and rules and regulations. She's been a compliance officer, worked a lot with the ACOs, and she's really made a difference and has made a lot of positive changes. She's been a go-to person for me for many years, so I just want to thank Ann for all of her work.
Congratulations.
I guess we're ready for Christie.
Okay, so for the January, the 7 months ending in January of 2022 and 2021, this January we had almost 5,800 visits to our outpatient services and our behavioral health compared to almost 5,000 last year, so we're about 1,000 or 800 more visits there. Year to date, we're at 39,700 plus compared to just 37,000, did I say that right? 39,700 plus. This year, $37,700 last year for the 7 months ending. So have seen a substantial increase in our services in outpatient behavioral health. ER, we had close to 500 visits this year. In January, 330 last year. We've had 3,500 visits to our ER so far in the 7 months compared to 2,700 last year. Surgical procedures were down this January at 88 compared to 115 last year. We're down 5.7% for year-to-date for June 30th or January 31st of 2022 compared to January 31st of 2021. The physician clinic visits, again, we continue to see a big increase in those. We had almost 4,100 in the month of January of 2022, and it was 3,100 in January of 2021. 28,000 plus for the year-to-date for the 7 months compared to almost just 24,000 last year, a little under 24. So that is a 17.7% increase in our clinic visits. Our average daily census for our inpatient swing bed and observation patients was 10.61 per day. Last year it was 9.62, 10.7 year-to-date, 9.25 year-to-date for 2021. So we are seeing a 15.7% increase in that, and the majority, pretty much all of that is in our acute care patients.
How does that look compared to 2019, Christie? I mean, I asked just because when I'm comparing things right now, I'm looking back 2 years. I'm just curious to do.
Yeah, I haven't looked at that.
That's fine.
Go back and look.
I would just be interested in that sometime because.
I would say it would be pretty, well, for our inpatients, it'd be pretty consistent this year, consistent with, because we have seen a decline in our inpatients, so it's nice to see the rebound a little bit there.
Just throughout the pandemic, the concerned people weren't getting care.
Yeah.
I hope we're climbing back up to where we were pre-pandemic, maybe with people that are comfortable with and looking to come back and get care if they need to, so.
Yeah. I would estimate that our outpatient behavioral health visits are significant, or higher than what they were even in 2019. We had a great influx of outpatient specialty doctors and services here, and very active at behavioral health too. So ER fluctuates, but we usually have 5,000 to 6,000 visits a year. So again, I think that would be pretty comparable. Births for January of 2022 are the same, 3 for January 2021. We are 70% higher in year-to-date for the first 7 months of 2022 fiscal year end to 2021. So we have 46 so far since July 1 and we had 27 in the previous year. So pretty good increase. We're happy to see that. Our net operating income was a loss this month of approximately $90,000. We had $14,000 profit in last fiscal year for January. Year to date, though, we are at a little over $203,000 in net operating gains compared to $679,000 loss last year. So pretty good increase there. Our net operating, non-operating revenue less expenses was a negative this time, and that's as a result of a fluctuation in the markets with investments. We all probably personally know. So for January of 2022, our net income is a loss of $93,000. $622,000 for last year because of some additional funding that was incorporated in there for COVID. This year to date, we have $2.7 million in net income from all sources compared to $2.2 million last year. I look more at the year to date because some months there are different things that come through that are only once a year type things. So really we're on budget with, you can go to being in a profit. If we look at the balance sheet that's in your financial report, our cash is remaining pretty consistent. We're up a little bit in cash. Our investments are higher. We've invested a little bit more money into some more of it equities to try and get a better rate of return. Accounts receivable with seeing the increase in revenues and services that we've provided, plus we've utilized some contract coders to get coding more timely. We've had significant strides in that, so that would be a reasoning for our accounts receivable to be higher. Until those claims process through the payment cycle, it will remain a little bit higher. In liabilities, our payables are pretty consistent. We no longer have any long-term debt, so there's no current portion or long-term debt there. We have paid off approximately $1.5 million in those advance payments from Medicare that were available. That will increase, that will go down faster because eventually they'll start taking our, but our cash is significant, is enough to withstand them taking that back, so. Any questions on the financial reports then? Okay, 19, what is, yeah, so.
It's February 111.
In February of 19, our outpatient visits were 3,328. So you compare that to our January is 5,793, so we're pretty significantly higher there. Compared to 19. Yeah, we're 8,000 higher year to date. It's additional months, but so we'd be approximately $5,000 visits higher in outpatient this year
I think
versus.
that's strong, and that says a lot about where we are overall here today, so thank you to your data assistant for finding that over there.
Physician clinic visits are pretty consistent with what they were in 19 now.
Do you have big behavioral health identified?
I don't have those separated out on this one. I can get those. I mean, I keep statistics back forever, so I can do some comparisons and
And in
reports.
2019, we still had a bit of a bottleneck of behavioral health compared to where we are.
Yes.
Because we weren't relocated then,
Correct.
so that would be maybe a nice little pathway.
Okay, I'll pull some more historical farther back data together then. It's all available, it's just putting it in the format. So I can take care of that.
Thank you.
Thanks, Christie. I'll need approval for the monthly financial statements, please.
So moved.
I'll second the approval of the financial reports.
All in favor, say aye.
Aye.
The same.
Aye.
Okay, now we'll need the payroll and claims approval.
There's been no questions or
No
nothing out of the ordinary.
I'll move the approval of the January payroll claims.
I'll second.
second it.
Thank you. So Tom has seconded it. All in favor, say aye.
Aye.
Opposed, the same. Okay, I guess we're ready for adjournment.
I make a motion to adjourn.
Jim has made that motion, and,
I'll second.
okay. All in favor, say aye.
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 Thank you, everyone.
Thank you, Leland.